Hi, everybody. This is Dr. Nasir Gami. Thank you for joining for this podcast episode. We're going to be discussing mood temperaments, which is a topic that's gotten some interest. And I titled it by saying it's a clinical secret. And that's because I think this is probably the aspect of clinical diagnosis and treatment that most psychiatric clinicians don't know about or incorrectly interpret. And this would include me. And I've been in the field for more than 2 decades. And I would say it's only the last decade or so that I've been paying attention to the concept of mood temperaments. And in many patients, it's revolutionized the treatment. I would say, especially in an outpatient private practice type setting, this is very important and relevant. Maybe less so in the inpatient setting where patients are more severely ill, but in the outpatient setting, very relevant. So, what is the concept of mood temperaments? We'll talk about it for a few minutes, and then we'll have a discussion with Daniel. The idea is that these are mild mood symptoms that are genetically and biologically related to manic depressive illness, but they're present all the time as part of one's personality. So, these are not like symptoms you get as part of a mood episode that lasts a few months and goes away, and then you're quote unquote back to normal. Actually, this is your normal. This is your baseline, but your baseline's a little abnormal. So you could be a little manic all the time. That's called hyperthymia, hyperthymia, hyperthymia. And this is not in DSM 345. It's completely ignored by contemporary psychiatry. Most people have never heard about it. If you Google it, you won't see much about it, except recently some things like I've written. But it actually goes back 100 years. It's not online, but in the books. It's been described since Ernst Krushmer in the 1920s as mild manic symptoms as part of your personality. And that's when you're always high, a little energetic, very productive, very active, can be very charismatic, creative. You see hyperthymia in a lot of productive, successful people, especially entrepreneurs, creative people, businessmen, and leaders. It's not a bad thing in that sense, but it also is in the sense that you can be a little impulsive and you tend to be very future oriented, which is good, but sometimes you're not willing or able to deal with the past. Another benefit, though, is that you can be very resilient to trauma because you kind of keep going. So hyperthymia, hyperthymic temperament, is an important mood temperament. The opposite is dysthymia, where you're a little down all the time. People have heard about that because it's in the DSM system, but incorrectly, because DSM lists it as if it's a separate illness, a separate diagnosis. And so it's as if it's an opposite thing from, say, bipolar illness. But actually, you could have bipolar illness and be dysthymic in between your mood episodes. And you can have unipolar depression, so-called major depressive disorder, and be hyperthymic in between your depressive episodes. So manic depressive illness is really all about this. It's about mixtures of manic and depressive symptoms in lots of variations. And it's not just about whether or not you have a manic or depressive episode. In fact, it's really common for people to have depressive episodes and to be hyperthymic or manic in between the episodes. They never have full-blown manic episodes. It's not severe enough to last a week or longer with the whole list of symptoms. They don't even have hypomanic episodes lasting 4 days, which is scientifically unproven. Nonetheless, in the DSM system, then they would not be diagnosable with bipolar illness. But they do have hyperthymia, which is manic symptoms. So they do have manic depressive illness. So dysthymia is the opposite. That's more well known. And then the third mood temperament is cyclothymia, or cyclothymic temperament. This also people think they've heard about because it's in the DSM system, but again, incorrectly, because it's not listed as a personality type, as a state that you are in between mood episodes. So cyclothymia is when you go back and forth between manic and depressive symptoms all the time. People often focus on just the manic side and they say they're depressed a lot, but actually they have some manic type symptoms. I'm sorry, they focus on the depressive side. They say they're depressed a lot, but they actually have some manic type symptoms too. Again, some impulsivity, brief spurts of energy, periods of feeling high just for a few hours, and going back and forth in their moods. Now, the important thing about cyclothymia and hyperthymia, in particular, these manic temperaments, is that they are constant. They are not episodic. So a lot of people, most people, say that if you don't have a discrete episode of manic or hypomanic periods, then the person doesn't have manic conditions, and because they say it's not bipolar illness by the DSM definition. Maybe not by DSM definitions, but they do have manic symptoms as part of their personality, and that's part of manic depressive illness. So a common mistake that's made is people say, oh, the patient's not bipolar, no manic episodes or hypomanic episodes, so it's irrelevant to their ADD or whatever else. But in fact, they're ignoring that they're manic all the time. They're mildly manic all the time, hyperthymic or cyclothymic. And that's just being ignored. It's part of their personality. So the mistake that's made is that it's not seen as different from their baseline, and therefore it's viewed as nothing. But in fact, their baseline is not normal. It's a little manic. We did a study once that showed that about 1/2 of all patients in our mood clinic had mood temperaments. 1/2 did not. So about 1/2 of patients may actually have normal euthymic baselines, but about 1/2 don't. They're always a little manic, or always a little depressed, or always both. And that also leads to another common mistake, which is to view this baseline as quote unquote residual mood symptoms, which then people say we should treat with even more medication, even more mood stabilizer, antipsychotic, antidepressant, which isn't going to get you anywhere because that's the baseline. That's not going to change. You're just causing harm by adding more medications. You're not making patients better. This is another pseudo problem in psychiatry, the so-called challenge of residual mood symptoms. There's no challenge of residual mood symptoms. You should leave patients alone when they get to their baseline of mood temperaments. Now, another aspect of mood temperaments, because they're not diagnosed, is that people see the effects and they diagnose those and try to treat those instead of trying to treat the cause, which is the mood temperament. What are the effects? Well, if you're moody, if you're down, if you're manic, mildly, you will not often concentrate very well. That's part of the definition of manic and depressive states. And since the mood temperament's being ignored, those people get diagnosed with so-called attention deficit disorder. And that's a mistake. Well, if you're moody, you get anxious when you're depressed or manic. Mood temperament's ignored, people get diagnosed with so-called generalized anxiety disorder, GAD. That's a mistake. Sometimes the depressive symptoms are so obvious that people use the label major depressive disorder, MDD, even though they really don't have full-blown depressive episodes that come and go. It's just constant mild depressive symptoms. So my half joke is that when a patient is diagnosed with the false comorbidity of MDD and GAD and ADD together, they actually have cyclothymia. The treatment is not an SRI plus an amphetamine plus a benzodiazepine, which we see over and over again, which is the treatment for the effects, and that doesn't work so well. The treatment for the cause takes care of all of those effects, and that can be low-dose mood stabilizers like lithium, 300 to 600 milligrams a day, valproate, 250 to 500 milligrams a day. There's actually a little bit of clinical observational research to support that. There's not randomized data. There's not a lot of trials. So one can't say with a definite confidence what the best treatment is based on that kind of evidence. And that's because people aren't diagnosing these mood temperaments, and therefore there are no studies that are randomized to assess their treatment. But based on the observational studies that are out there, which is my own clinical experience as well, low-dose mood stabilizers like lithium, 300, 600 milligrams, valproate, 250 to 500, can really improve cyclothymia and hyperthymia. And then suddenly the ADD, MDD, GAD goes away. So that's my basic thinking about mood temperaments. I'll just say one more thing, one more relevant fact. Mood temperaments are things you have in between mood episodes, as I said. But you also find it a lot in family members of people with manic depressive illness. And some of those family members only have the mood temperaments. They don't actually have mood episodes. They're not diagnosable with unipolar depression or bipolar illness. They just have cyclothymia or hyperthymia, or sometimes dysthymia. Well, mood temperaments predispose you, though, to an increased risk in the future of mood episodes. So you might be cyclothymic, hyperthymic for 40, 50, 60 years, and then have your first mood episode, your first depressive episode, your first manic episode in your 50s, 60s, 70s, even 80s. So this middle life onset, late life onset depression or mania, which people often scratch their heads about, is actually not such a problem either when you realize it's not really middle life and late onset mood illness. The illness began with the mood temperament at age 2, even though we don't diagnose it as a mood illness until they have their episode at age 50 or 60. But actually, it's not late onset mood illness, it's a late onset mood episode in someone who has underlying mood temperament, which actually predisposes you to that. So that's another aspect of mood temperaments that's important and can often clarify issues for patients. So I said it's a clinical secret. In my clinical practice, I see patients coming to me with ADD, GAD, MDD. They haven't gotten better with SRIs, amphetamines, benzodiazepines. I give them the Temp Scale. I assess their mood temperament clinically, which we can talk about. The Temp Scale is a well-validated scale for this with hundreds of studies. You can download it from the internet on our website, psychiatryletter.com. We have a 50-item self-report that you can download it. You can get it from the original papers. We have a scoring guide there as well. I give that to all my patients in my private practice, especially before they see me, and then I assess them when we talk. And if they score more than 3/4 of the items or close to that, and it correlates with a clinical history, then I often diagnose a mood temperament and then shift from that polypharmacy of ineffective symptom treatments to treating the cause with one low-dose drug, a mood stabilizer, which often gets people a whole lot better. So I'm going to stop here and invite Daniel Herringer to join me again, a psychiatry resident colleague from the Cleveland Clinic. Hi, Daniel. It's good to see you. And let's have a discussion.
Yeah, I love this topic. It's such an interesting perspective because it really explains what we see in reality all the time. But in the DSM, we don't have the good names for it, right? And when you talk about the family members, I kind of have the sensation that it's kind of like a sprinkles of genetic traits that's spread all over the families, and some people have more of those sprinkles. Some people have less, and when you pile up all of the factors, then you have presentations that are more marked and less marked, and that's very easy to correlate with other biological phenomena such as height, weight, and whatever else. So I have so many questions, but I wanted to start with an easy one and kind of get your take on it, which is about patients with hyperthymic mood temperaments. So it's easy to remember. I think everybody who's listening to this is going to be able to think of someone, a friend, a colleague, someone from medical school. They were super smart and they were at all the parties, but they would score super high on all the exams. And they were like, how does that person can do all this and sleep so little and be always so positive? And it's easy to remember those people. But then I think sometimes they do get like some episodes of feeling low. They're still like, when you compare them to everybody else, they're chilling. Like they're kind of normal. They're doing their job. They're going to school. They're going to work. They're just not as they usually are. And that can last for a few weeks. And that can cause a lot of suffering as well. And to me, it's a very logical biological phenomenon of like a high baseline and coming down, but not quite down as much as what we would call most of the time a clinical depressive episode. And I wonder how you interpret this kind of phenomena, if you can recall and identify this as happening, as well as I have seen this happening a few times, and how we should interpret this and approach this if some people come and ask for us for help in this kind of situation.
Right. Yeah, I think that's a good question, because if you don't think about the concept of mood temperaments and you don't even know what hyperthymia is, you'll make a big mistake with these patients, because you'll ignore all that. You don't know about it. And they just come to you, and as far as you can tell, oh, here's a guy who was highly functional and sociable. Great. And now he's in a depressive episode, and you just give him an SRI or something. That's what most people do. They just think of it as just another depressive episode. But if you think of it as hyperthymia followed by a depressive episode, then you're getting at the cause. The reason the patient's depressed is because he was hyperthymic. If he wasn't manic, he wouldn't have gotten depressed. This is the theory of Athanasios Koukopoulos, the Greek-Italian psychiatrist who talked about this and called it the primacy of mania. We have a paper on that I'll put in the link later. The idea is that his view was that depression doesn't happen unless someone's manic before. Could be a full-blown manic episode, could be a hypomanic episode, could be hyperthymia, could be cyclothymia. But if you don't have one of those things, you don't have severe depression. You might have depressive symptoms for other reasons that are not severe, not recurrent, as we see in manic depressive illness. But if you have recurrent severe depression, it's preceded by manic symptoms or episodes, according to him. And so if the mania precedes the depression, it could be logical that the mania causes the depression. And if it causes the depression, then what should you treat? The effect, which is the depression, or the cause, which is the mania? And so the theory is you should treat the cause. And so with a patient like that, with hyperthymia and then a depressive episode, instead of giving an SRI, so-called antidepressant, you would give lithium or Depakote at low doses as a mood stabilizer, second messenger modifier, term I prefer, which actually gets at the cause and then prevents the future depressive episodes as well.
Got it. That's an interesting take. I know Koukopoulos has published a few alternative diagnostic criteria for MDI as well, and they're very useful and broad and easy to identify in a lot of.
Yeah, let me just say, you just made that point. The other reason he thinks mania and causes depression is that mixed states are the most common episode. So it's not an accident that the patients are mixed. If they didn't have the manic symptoms, they wouldn't be depressed in the mixed state. And so that's why mixed states are so common. So that's another rationale he had for that. Go ahead, yeah.
Oh, just point out, great observation. And I remember because I've had patients with following for years with little to no improvement, diagnosed with personality disorders, and they would meet all of the criteria according to Koukopoulos' scales for MDI. And it just reminded me of that from years ago. But I had another question. This one's a little bit more on the tricky side of things. And it's about, I don't know, a linguistic approach to this. Should we be calling mood temperaments as a diagnosis? Should we be identifying this as pathologies, as something that deserves intervention? And what would be the safe approach to this? What makes me worry is psychiatry has a historical issue with over pathologization. I'm not sure if that's the word, treating everything as illness, and that makes me worried. If we are too liberal with this kind of thing, where does this lead us?
Well, there's two answers to that question. One is, I think it's a major flaw in psychiatry and a reflection of stigma that we say we shouldn't diagnose people with mild symptoms. We should only diagnose them if their symptoms are severe and if they have a lot of functional impairment. That's the DSM standard for almost everything. But imagine if you're an oncologist. Would you take that approach? What do you think, Daniel? You're an oncologist. Should you only diagnose severe symptoms and functional impairment? Oh, you got a little bit of cancer. Forget about it. We'll just ignore it. Is that the approach you would take? No. How about if you're a cardiologist? How about if you're a cardiologist, Daniel? Should you say, oh, yeah, if you get severe chest pain and you can't walk, okay, we'll do an angiography. But if you have mild chest pain, we won't. Would that be a problem?
No, I think that's a suboptimal approach. Are those examples?
So what if you're a dermatologist? Oh, yeah, there's a little bit of a skin something here, but until it gets huge, we won't do anything about it. Is that the approach you would take?
No, not at all.
Can you think of any other specialty in medicine where we ignore mild symptoms?
I think in primary care, when patients come with very vague and weird stuff,
but
we ignore
primary
them
care makes a lot of mistakes,
that.
right? The headache gets ignored, and it's a brain tumor. The sniffles get ignored, and it turns out to be a serious pneumonia. I mean, they know better than to just say it's mild, don't worry about it. They'll at least worry a little and think about other options.
That's all of that is true about the dermatology and cardiology and all that. But there are reasons that we came to be this cautious, right? Like historically, we learned that we should be cautious about that and not be calling everything diseases or
I
disorders.
don't know about that. I think that that's kind of that's one of the cliche assumptions of the postmodernist anti-psychiatry crowd. They don't want to call anything diseases. I'm quite willing to call 1,000 diseases if there are 1,000 diseases out there, and I'm willing to call 2 diseases if there are 2 diseases out there. Why do we have to say there can't be 1,000? Maybe there are. That's not up to me or you. That's up to nature and God.
Fair enough.
So let me answer your
But
question though, because I
yeah,
was trying
so
to make
what would
the
be the
point.
best approach?
Yeah,
Okay.
I was trying to make the point that if we believe that psychiatry should be on a parity with medicine, that we should be treated equally with other branches of medicine, why are we thinking completely differently from them? Because we are self-stigmatizing. We should be aware that mental health professionals and psychiatrists actually stigmatize mental illnesses and people with mental illnesses. We think we don't because we're involved with them, we treat them, but actually we do. We have discrimination against them and against the illnesses. And that's reflected in this DSM-based, postmodernist-based reluctance to diagnose mild conditions. My point is only if mild conditions are scientifically legitimate, we should diagnose them. If they're not scientifically legitimate, we shouldn't. But we shouldn't prejudge it and say, oh, just because it's mild, we won't diagnose it. We're against it. That's unscientific, anti-medical, unbiological, stigmatizing, and discriminatory, not to mention harmful to patients because we're not actually helping them the way we should. Now, regarding the issue, though, whether we should pathologize mood temperaments, having said what I've just said, I'm going to back off and say, I don't know that I'm not saying, and I don't know that that's the right attitude to say that mood temperaments are an illness. I'm not saying they're an illness. I am saying they are biologically and genetically related to an illness. They're part of the spectrum of manic depressive illness, the mildest variety of it. That doesn't mean that you could view them as necessarily a disease. Another example might be you could have very mild hypothyroidism. It's part of the spectrum of thyroid disease. That doesn't mean it's not related to an illness. But you might not say it's an illness if it's really mild, but it is abnormal. And then the question is, what's the relevance of it? Same thing with high cholesterol, high blood pressure. Those aren't actually illnesses. Those are risk factors for an illness, namely stroke and heart attacks in the future. And so we can think of this the same way. Mood temperaments are risk factors for future mood episodes that can be quite dangerous. If you go from hyperthymia and you're always a little high to a severe depression, that's a pretty big fall, and people can get quite suicidal. I have a friend who in the past was hyperthymic and had 2 depressive episodes separated by 30 years. And in the second episode, he died by suicide. It's a very risky thing. So the risk is not in the present, but this condition tells you the risk will be there potentially in the future. And in the present, then, though, the relevance is not so much the mood temperaments, not the moodiness per se, usually. It's the effects of the moodiness. Like I said, they can't concentrate, mislabeled ADD. They're anxious, mislabeled GAD. They're a little down, mislabeled MDD. That does interfere with their lives. They come to clinicians for help. They get misdiagnosed as not having mood temperaments. They get all these other drugs which make them worse or cause more side effects or don't make them much better. But if we diagnose the mood temperaments by treating the mood temperament, it's not the moodiness that really matters, but you get rid of all the other effects which do matter. And the patient's much less anxious, much more able to concentrate, a little happier, and able to live a better quality of life. So we don't have to call that an illness, but it is related to an illness, and it causes other symptoms that people actually are pathologizing correctly, in my view, in psychiatry and calling illnesses. We have some chat questions about borderline personality too, Daniel. I don't know if you want to get to that, but that always comes up when this is discussed.
Yeah, I think. I think the broader question is that Larry brought up the borderline personality disorder and cyclothymic. But I think the broader question is how to differentiate all of those mood temperaments, or with uh, with personality disorders in general, and GAD in general, for example. The
Well,
patients with
yeah, sorry. The easy answer is GAD doesn't exist as a valid diagnosis. It's totally made up, has no scientific validity to it. So we don't have to worry about that. Can we just drop that, Daniel?
okay,
Well,
right.
you have to always start with, is it valid? Because you can make up 1,000 false things and then start worrying about them. What's the point of that? You all right with dropping GAD?
All right, I'm all right
Can I
with
drop
dropping
that?
GAD.
All right.
Okay.
So let's go to personality disorders. The concept of personality disorders is invalid also and scientifically false. The whole concept is false. It's made up based on psychoanalytic ideas from 1980 that have never been validated. It's just been replicated as being reliable. We can define things a certain kind of way. But you remember in DSM-5, the Personality Disorders Task Force wanted to get rid of 6 out of 8 of the so-called personality disorders because they were invalid, scientifically disproven. And yet a letter writing campaign by John Gunderson and a bunch of psychotherapists led the DSM Board of Trustees to keep it at the last minute. Do you know that story?
I've heard of it.
All right.
Like
So given that the personality disorder task force experts, and these guys were researchers, actually said 6 out of 8 are invalid, can we just drop them and not talk about them either?
and the ones that are not invalid would be the
Everything but
antisocial and
borderline and
borderline.
antisocial. Everything but borderline. So everyone's favorite, narcissistic, invalid, no scientific validity to it at all. And all the rest, dependent, avoidant, schizoid, blah, blah, blah. So we can talk about borderline if you like, but personality disorders as a general concept is actually quite meaningless.
Okay, so let's go. Let's go to
All right,
borderline versus
So
mood temperaments.
my big picture view on this is that cyclothymia, as I said, is about mood symptoms going up and down. Borderline personality is mistakenly thought about as mood symptoms going up and down because that's one of the DSM criteria that's never been validated. There are 9 criteria in DSM, 6 out of 9 for it. And they include things like that, which are non-specific, not validated as specific to borderline personality, not validated as being consistent in borderline personality. When you look at the diagnosis validation studies and the general concepts that led to borderline personality, it was about sexual trauma early in life, leading to self-cutting and self-harm, and a, psychologically speaking, kind of all or nothing attitude towards people, love and hate, leading to a lot of anger, hate in the countertransference, and so on. Where is that in the DSM criteria? None of that's there. There's no countertransference. There's no sexual trauma. It's not even included as a diagnostic criterion because DSM doesn't like to have any causes. So it puts in all these non-specific aspects of the diagnosis and leaves out the actual core specific aspects of borderline personality, which is sexual trauma, dissociative states, self-mutilation, not suicidality, self-mutilation, self-cutting and self-harm, and extreme anger, usually brought out in an emotional relationship, not just in a general sense, like with the therapist and the client. So this whole idea that, oh, we can't differentiate borderline personality from cyclothymia because they're both moody is false, because the moodiness is not central or really relevant to borderline personality. These other aspects are. But the moodiness is central to cyclothymia. That's what it is. It doesn't have sexual trauma, self-mutilation, dissociative states. So it's very easy, actually, to distinguish these two.
You just have to know what's really important.
Well, I mean, you don't say, oh, I can't differentiate a migraine headache from a brain tumor because, oh my God, the headache, the pain in the head is so terrible. You don't focus on what 2 conditions share. You focus on what's different between them to differentiate them.
Fair enough.
And one last question here, I know from the interest of time, Daniel, there's a good one that came up on the chat. Everyone always talks about this. As soon as you mention lithium, everyone's like, well, what about all the harms it has? What about the risks? So this question was, what about the risks and benefits of using lithium for mild hyperthymia? And there's no point in saying mild hyperthymia. Hyperthymia is mild. So it's, by definition, it's just mild. So hyperthymia, there's no such thing as severe hyperthymia. It's just hyperthymia. Well, I said low dose lithium, 300 milligrams, 450 milligrams, sometimes 600. At 300 to 450, you get blood levels of about 0.2, 0.3. You don't even need to check blood levels because it's always going to be low. The kidney is not going to be affected at all. The kidney effects of lithium And these numbers are really important. People always just have these generic, false, vague feelings. It's important to really quantify these risks. The kidney effects of lithium are 1 to 5% chronic kidney impairment at full standard doses after 20 years of treatment. 1 to 5% at 20 years of treatment with full doses. Here we're talking about 1/3 to 1/2 of the usual dose. That means you're going to have 1 to 5% at 30, 40 years of treatment at best. So the risk is really quite low. 95 to 99% of people don't have kidney impairment with lithium anyway at standard doses. Much more than 95 to 99% would have no issues with low dose lithium. Thyroid effects might be there, but it's reversible and treatable, so really not a concern. Most people who I give lithium to at these doses don't notice it at all in terms of any side effects, and the harms are really quite minimal. So the benefits far outweigh the risks or the harms.
Great. And I've heard that saw this new study in the Netherlands that did not find any difference in kidney issues in patients with bipolar, whether treated by lithium or anything else. And it was
Yeah.
like a gigantic study, millions
Right.
of patients, and I was like, wow, that was surprising as well. Anyways, I know we're kind of out of time, but I need to ask one question. It was like kind of practical. Those patients that we see that are primarily anxious, so they're the primary thing that bothers them all the whole time is anxiety, and sometimes they're like panicky, and they do have depressive episodes. How should we interpret this kind of situation with those lenses that you just presented?
Anxiety is like fever, just like attention is like fever. It's a very non-specific symptom in psychiatry. It's not a cause of anything, it's an effect, usually. And so you need to look at what the causes are. Often the causes are mood conditions, depression, manic states, and mood temperaments can be an important part of that, where you get a misdiagnosis of generalized anxiety disorder because someone has cyclothymia, hyperthymia, and they're always a little anxious all the time. So give the Temp scale, do the clinical history. If you get that kind of history, then you can make the diagnosis of the mood temperament, treat that with a low dose mood stabilizer or second estrogen modifier. Valproate is really good when anxiety is the main issue because it also has a direct anxiolytic effect, and that can help. However, there are plenty of other conditions where people can have anxiety states for other reasons other than the mood temperaments. Neurotic depression, for instance, which is a different scenario where they have high neuroticism as part of their personality, and this leads to also brief reactive depressive episodes. That's something to look at. And people can just have neuroticism and not have mood temperaments at all, just high neuroticism as a personality trait. And you can look at that as well. And, more complicated to decide what to do about it, but at least you've ruled out the mood temperament then in that case. Let me just say one more thing about how to do the historical assessment on mood temperaments, and then we can stop. I always ask my patients, tell me what you're like in your usual personality. What do you like when you're just yourself, when you're feeling okay, not depressed, not manic, not if they have episodes? And then I write down in verbatim quotes what they tell me. And if they don't tell me enough, I ask about the standard personality traits of the neo, neuroticism, extroversion, openness to experience. And that often brings it out. But sometimes they'll just say, I'm really outgoing, always happy. Everyone says I'm sunny. I'm a workaholic. And I love to do marathons 5 times a week. And then I bungee jump on the weekends, and I like skydiving in the summertime. And I'm like, you can do your Temp scale, but they're going to score high on hyperthymia. So that's the kind of thing you want to be looking for, and ask patients about their personality when they're normal. That's how you get at mood temperaments.
Awesome, amazing conversation. I feel like this topic is so interesting, and we just want to keep talking about it. We should get back to this sometime. Thank you so much, everyone who's been watching and sending so many questions. I'm sorry we couldn't go over them all today, but we should get back to this conversation in another opportunity. Please share this if you found this interesting. If you found that this could be helpful to someone else, please share this video with someone, and we'll be back again. All right, Dr. Agami, thank you so much. It was an amazing conversation.
I appreciate it.
All right.